we'll talk. All right. So today we'll briefly talk about cell-free DNA and the history, the discovery, clinical application, detection techniques, correlation to acute rejection, test accuracy, and the role in combined organ transplantation. So, what is cell-free DNA? Cell-free DNA refers to the freely circulating DNA fragments in the plasma that happens due to um, um, turnover of the nucleated cells. So our cells kind of undergoes turnover in the normal turnover or in under like different circumstances such as injury or trauma or severe infection. The cells would spill its content, and that um, DNA will be in the circulation outside the cells. And that is essentially what is cell-free DNA. Now, these fragments can reach up to 150 base pairs in length. And I used this picture here to kind of refresh everyone's memory of the DNA. So this is the double helix, and these are the pairs or the base pairs. So under normal turnover or under stress, we see fragments of the DNA circulating, and we have now the ability to measure these and identify them and identify who they belong to, the host or the organ. And we're going to go through different applications here for that cell-free DNA. So a brief history and kind of walk you through this um, timeline. So in 1948, Mandel and Matthias were the first uh, scientists to discover that. Later on, they thought about applying this in cancer research. So the cancer cells will undergo turnover and spill the content. Now, each cancer may have different DNA in terms of like different signature of DNA. So they wanted to look into that. So they discovered that when there's high cell turnover for the reason of cancer, they may be able to measure the cell-free DNA, and if it's high enough, they can pick up a threshold and determine if this person has it or doesn't have it. Later on, 1966, they decided to use that cell-free DNA technique in autoimmunity. So in subjects who are dealing with lupus, for instance. And then in 1977, it was determined that cancer patients would have higher level of cell-free DNA. Then in 1989, they were able to pinpoint kind of certain cancers, so lung cancer, pancreatic cancer versus prostate cancer. 94, they were able to get the signature for acute myeloid leukemia. In 1999, they started using this technique to assess the health or the wellness of the organ transplanted. So Zhang looked at the cell-free DNA. You can find cell-free DNA in the urine, and you can decipher if it's self versus the donor kidney. And then between 2000 and 2019, with the advent of technology and the ease of use, now we were able to apply or use that cell-free DNA technique in kidney, pancreas, heart, liver, and lung. So are there other applications for cell-free DNA? Well, there are a few. So the most common cell-free DNA application is right now is its use in pregnancy. So uh, the the mother has their own or her own cell-free DNA, and the baby has cell-free DNA that spills over to the maternal circulation. So these are, again, pieces of DNA that are outside the cells and they are in the circulation. The test is able to detect that cell-free DNA, one, quantify it, see how much of it is there. Two, because of the SNPs techniques, which we will talk about in a minute, the test is able to discern between the source of the DNA, mother versus child, in this case. Then the application of cell-free DNA here is to test the baby and look for mutations like trisomy 18, trisomy 21, or other genetically mediated disease that we have um, uh, sequence for that we can detect and test. And because pregnancy is far more common than organ transplantation and tumors, that's the number one application for cell-free DNA. In the settings of organ transplantation, so we have the organ that comes from the donor, and we have the recipient. So similarly, when we run the test is able to distinguish between the cell-free DNA that is coming from the donor and the cell-free DNA that is coming from the recipient. And under normal circumstances, if the organ is well and the body or the host body is not attacking the organ or causing any damage to the organ, then the organ is intact and the cells are not spelling the the DNA. Therefore, the level of cell-free DNA that is coming from the donor will be very, very, very small as compared to the portion of the cell-free DNA that is coming from the recipient. And through testing and verification, um, the test can, now we have threshold, or the initial studies determined threshold beyond which we would deem that this is an ongoing damage to the transplant organ, or in this, i.e., rejection or other injuries. And for each organ, there is a cutoff. So for the kidney, which we're going to come to here soon, is about 1%. If anything under 1%, then it seems like the kidney is doing well. And if it's above 1%, then that will make us worry about rejection. And there are some caveat to this that we're gonna talk about. So the detection technique. So early on, when we are trying to decipher where is the DNA is coming from, is it coming from the donor? Is it coming from the recipient? Then one technique was based on the Y chromosome. And this technique would eliminate many donors. So the assumption here, you were only going to be able to look to distinguish if the donor was male and the recipient was female. And if the test is only going to look at the Y chromosome region, so those who are female to female transplant or male to male transplant will not be picked up. So that idea did not work very well and was, we felt the field felt the need to have a better technique to pick up the different DNA, and to try to classify donor versus recipient. Then another technique later on was proposed. If we know the HLA of the recipient and the HLA of the donor, and we know where is this HLA maps to, then in terms of chromosomes, then we can look at the chromosomes and decipher if this chromosome produced that HLA or that chromosome produced HLA. But in order to do this, you have to know the typing for the donor and the recipient, and this can be difficult under certain circumstances. Then, because of the advances in the PCR technique or the polymerase chain reaction, and the identification of DNA and the genome study, there is something called single nucleotide polymorphism, or if you may, this is the fingerprint of every person, that the DNA print. And we have so many variations that the test can easily pick in two different DNAs, even if one is such a small amount, like in the settings of organ transplantation. So with the single nucleotide polymorphism, or the polymorphisms, so-called SNPs, the test now is able to decipher between the donor source and the recipient source without relying on HLA, without being limited to test those who are female recipients of male organs. So now the test was, like, is able to be used and applied in under many circumstances. And those who are closely matched, they can still differ. So in the settings of um, very close relative and such, the test is able to pick that up. Um, so the stability and the time course in the cutoff. So now when we look at the cell-free DNA, again, we said the donor should constitute very small fraction, and the recipient cell-free DNA should be the majority of what is measured. Um, and there are cutoffs. So different organs will shed cells at different rate, and therefore will have different cutoffs. So the liver is larger organ than the kidney, and has different characteristics. So they found that the liver can shed up to three, or in the settings of liver transplant recipients, for instance, when they do the test can be normal if they detect up to 5%, between 3.3% and 5% from the donor cell-free DNA in the recipient. So if they run the test, they have this much cell-free DNA. If 3.3 to 5% of that DNA is coming from the donor, that may be okay. If it's higher, then it's a positive test. Now, these ranges vary by test. There are different tests available, and each of the tests will have a cutoff that is unique to that test. But roughly for the kidney world is around 1%. So lung will be different than kidney and heart, and so on and so forth. So in the setting of organ transplantation, so um, early on after surgery, the organ undergoes so many um, it undergoes so many conditions of engraftment and the sewing, the ischemia, reperfusion, injury, the immune suppression that we use up front and such, and how long the organ has been on ice. All these factors can lead to shedding. So some of the cells that and in the organ will be kind of leaking the cell-free DNA of these cells. And therefore, if we do testing in the first 7 to 10 days, we may detect higher level of cell-free DNA, even though that it may not correlate with rejection, not necessarily the organs being rejection. It's rather the organ is undergoing engraftment. And the same thing, if the organ is coming from live donor, so there's less cold ischemia time, then this organ may be well preserved, and therefore it may not shed as much as if it's coming from deceased donor. So now we learned about the cell-free DNA, how they measure it, and what's the concept, comparing the donor cell-free DNA to the recipient cell-free DNA, and trying to see the cutoff. And if it's high, then we have to suspect rejection. If it's low or normal, then we think that there's no rejection. But does it really correlate with the type of rejection, and what type of rejection does it correlate with more than others? So there are different kinds of rejection. So to kind of the general overview, we have cell-mediated rejection. This is when our immune cells invade the organ, or antibody-mediated rejection. That's whereby the body had identified the organ, formed antibodies towards the organ, and these antibodies are um, in the circulation, and they would attach to the lining of the organ, and then that will start inflammatory process, so-called antibody-mediated rejection. So they found that when the organ is undergoing antibody-mediated rejection, the damage is higher, and therefore it releases more cell-free DNA than if the organ is being attacked with cells. Um, but in all honesty, the test does not distinguish between an antibody-mediated rejection or cell-mediated rejection. The test will be high, and yeah, like let's say if we're investigating someone for rejection and we send the test comes back high, then we suspect rejection. We still have to proceed with the biopsy to know exactly what's going on with the organ. The test does not detect borderline rejection. So if the rejection is early on, or the cellular type, and it's early on and the organ is barely inflamed, the test may not detect any increased cell-free DNA. And therefore it can be false negative. Um, Studies showed that cell-free DNA may rise weeks before rejection, um, uh, or before we're able to tell if they're on the biopsy. So sometimes in under certain circumstances, so we'll use the kidney for example. We follow creatinine, and when the creatinine rises, we start worrying. Um, but creatinine may take very long time before it rises, and may not tell us the full story. So if the creatinine is normal, um, it may not tell us the full story. So there has been this notion that we want to know about rejection, and preferably and ideally before it even starts. If we wait until the creatinine rises, then maybe rejection is advanced, and um, if we know beforehand, or if we have a better test that tells us if the person is rejecting or not rejecting, then we can intervene early and therefore preserve the organ to the best of our ability. So that's kind of the idea or the concept that the field was aiming at. Another application that in the settings of rejection, when we treat the organ, so we hope that we had reversed the rejection in full, and therefore the test should come back to normal. So one application that we use the test for is after we complete the rejection treatment, we check the cell-free DNA, and if the cell-free DNA is normal again, then one can feel good about the rejection that they gave, the rejection treatment that they gave. And some programs would choose to confirm that the treatment work with a repeat biopsy or so-called closure biopsy. Some programs do this test, and if they have good experience with it, and if the test is negative, they feel reassured. If the test is positive, then they go back and look. If there is rejection, they decide on repeat biopsy, and so on and so forth. So in this slide, this is kind of, it gets into the correlation, and here on that side, I'm not able to use the indicator here, the sensitivity and the specificity. So to simplify this, sensitivity is when the test positive when there is rejection, and specificity is the test negative when there's no rejection. And you can see here the performance over the years. So when the test is positive, for the reasons that we mentioned, sometimes if the test is ordered early on after transplantation, and there are some um, content from the transplant organ being spilled in the circulation because of reasons other than rejection, then you'll have a positive test. But if you do the biopsy, you may not find the rejection. So um, that's kind of what factors in the sensitivity and the specificity. And in the case of the borderline rejection, you may run the test and the test is negative, but if you do the biopsy, you may find rejection. So a negative test with positive biopsy, so that impact the sensitivity. So the test sensitivity ranges depending on the study and depending the organ that is being tested. So we have sensitivity range that between 59 and 89%, and specificity um, that ranges that is a little better than the sensitivity here. We can get up to 98%. So what does that tell us? It tells us that if the test is negative, it's probably the performance for the test as negative in the right circumstances is better than if the test is positive. So that's kind of what we'll get into the negative predictive value of the test here in a minute with our experience in our institution. So starting in January 2020, we wanted to explore the cell-free DNA and use it. So we introduce it to in our practice to look for rejection or assess for rejection for cause. So we're not really doing it when we're not suspecting rejection. We only send it for in the settings of organ dysfunction, and we are trying to decide if this dysfunction is related to rejection or not. So we started incorporating that in our practice in January 2020, and we would test those who have kidney pancreas or pancreas alone transplant and see in the setting of dysfunction and see if the test is high. We would verify with a biopsy or and reassess and if they need it or not, if they need the biopsy or not, and then look at the cell-free DNA as one of the pieces to the puzzle for working allograft dysfunction. So during that time, we looked at all of our transplant that had dysfunction and we ordered the test. And the transplant, the time from transplant ranged between 1 month and 92 months. And just to briefly tell you about what we do so to put this in context. So for instance, a person with kidney and pancreas transplant, they get the routine labs. Then we look and we find the creatinine is elevated or the amylase and lipase are elevated. Then we typically reach out to the patient. The coordinator would reach out to the patient, ask what's going on, take a brief history, see are you dehydrated? Did you drink enough? Did you have enough bowel movements or whatnot? And then we discuss that with the coordinator and look at their immune suppression and generate a workup plan. Then we look for reversible causes. If the person is dry, let's hydrate them. If the person, in the case of amylase and lipase elevation, if the person is constipated and had not had a bowel movement for some time, then we say, well, let's improve their bowel habits and see if that brings down the enzyme. In the meantime, we would order the cell-free DNA to kind of help decipher, and we do the things that we do in general, and then we kind of decide on the biopsy the way we would decide on the biopsy otherwise. So patients with allograft dysfunction underwent donor-derived cell-free DNA testing as part of their workup, what I briefly mentioned. Patients with positive tests early on underwent biopsy, except for one patient that we're going to go through here in our case series, and that we know the background with chronic rejection, so that person was not biopsy. And if the person is within 6 weeks from transplant, they may we elect sometimes not to biopsy them. And if the patient had a negative test, but if we feel strong that there may be rejection going on, we would selectively pursue the biopsy. And those that have resolved dysfunction and the test is negative, we kind of consider that they were negative, and we don't have to worry about rejection right um, at that time. Um, our immune suppression regimen is the standard. So we use thymoglobulin induction. Most of our patients are discharged without prednisone, so they are on tacrolimus and Cellcept. During COVID, we had to revise our protocol, and we profiled our induction, and some of our patients would those who don't get thymo full dose, the 6 milligram per kilogram, they end up on prednisone during their first month. So I'm going to walk you through our SPK experience in those with confirmatory biopsy, and SPK with resolved dysfunction but without biopsy, in primary SPK um, with with cell-free DNA testing with and without biopsy, but early on, and some miscellaneous cases. And we're going to also cover some solitary pancreas transplant. The credit for this work goes to Heidi Sarumi, who helped um, review the charts, and Dr. Kandaswamy, who supervised all the work on the results that I'm going to report to you. So for primary SPK recipients here, this table will have the time from transplant, donor-derived cell-free DNA results, the organ that was biopsied, if any, and the correlation according to what the team had felt correlated or didn't correlate. So for instance, this is a case 15 months out of transplant. There was organ dysfunction. We sent the cell-free DNA, we investigated, we decided we wanted to do kidney biopsy to see what's going on for the dysfunction. The biopsy did not show rejection, showed some other things other than rejection, and the cell-free DNA was suggestive of a negative test. So we felt that this was a correlation. Similarly, here, this is another case 5 months out. There was pancreas dysfunction. We send the cell-free DNA as part of our workup, and we eventually biopsied that person, and we didn't find rejection. It was indeterminate. The dysfunction had resolved, and we felt that this was a good correlation. This one here, similar story with kidney dysfunction, SPK recipient with kidney dysfunction. We sent this cell-free DNA. We still wanted to make sure that the biopsy is, we wanted biopsy as part of our workup, and that was negative. We felt that this was correlation. We'll pick here this, for instance, this where the test was positive, and we initially we did the test, we looked at the enzymes, and with ongoing dysfunction, we repeated the test, and the tests were positive both times, and we did the biopsy, and this correlated. Another example where the test didn't correlate here, these couple cases where we did the test, the cell-free DNA was negative, we did the biopsy, it was borderline, although the disclaimer that the test does not detect borderline rejection. So you can have normal test, and if you do the biopsy, you may find borderline. So when you're using a new test and new technique, we always make sure that we apply our standards, so we won't miss rejection that we shouldn't. So, and it tells us that there isn't a single test that is perfect, and biopsy to detect rejection as much as biopsy. Biopsy remains the gold standard. If rejection is suspected, then biopsy will be the rule. So here, for instance, we had the test. The test was positive, and we did the biopsy for the dysfunction, and the biopsy was negative. And this case, although was quite complicated because it had other things going on, and but it's right to the point that, you know, when you try to diagnose rejection short of doing biopsy, the test is, there are tests that may be good, but nothing is going to be 100% as a biopsy. And the test performs better for if it's negative than it is positive. So here we have very good performance when, you know, like these are cases for SPK where simultaneous kidney and pancreas, there was dysfunction. We ordered the test is negative, the dysfunction resolved, and we felt good about that negative test to reaffirm what we were looking for. When we used the test under 6 weeks from engraftment, we ran into scenarios where the test will be high, indicating that there is higher cell-free DNA circulating from a donor source. But when we did the biopsy was negative most of the time. With one exception here, the test was positive early on, but eventually we were able to detect rejection. But all in all, when we're ordering the test, and if the test is positive in the first 6 weeks, that may be taken with a grain of salt, as there may be other reasons for a positive test during that period. Here, these are also different cases where a biopsy was not feasible, and we had to look for other alternatives to see if we can diagnose rejection or confirm our suspicion, or and so on and so forth. And this is, for instance, this case, 36 months out, primary SPK. We had allograft dysfunction, both the kidney and pancreas in this case. This is a case where there was COVID infection, and the immune suppression had to be dialed down. And with the ongoing organ dysfunction, every time we have immune suppression reduction, we worry if we precipitated rejection because of the immune suppression reduction. So we sent the test came back borderline. In this case, we were not able to obtain a biopsy, and the test was very close to the 1%. We followed our clinical judgment, and we covered that person empirically, and then subsequently they had stable course. Another case where a person was about 26, 27 months out of simultaneous kidney and pancreas transplant, dealing with PCP pneumonia. Immune suppression had to be reduced, and we ran into organ dysfunction. So we thought about rejections. We tried to biopsy. That person was not biopsyable because of the window or the anatomical constraints, despite several attempts. So we ordered the test. The test came back negative. And this highlights one shortcoming for the test. We suspected that there was rejection ongoing, and based on our clinical judgment, we wanted to pursue further measure or empirically treat. Then we realized that there was a very high background of cell-free DNA that was coming from the recipient. So this is about portion. So if the donor derived portion is greater than 1%, the test is considered positive. But in situations where the host, the recipient, has very, very, very high cell-free DNA in the background because of infection, then you may not be able to reach that 1%, and the test will be falsely negative because the donor cell-free DNA is very negligible amount, and the recipient cell-free DNA is way higher than normal because of the infection or the whatever circumstance that they are under, and their background cell-free DNA is very high. Then the test can be falsely positive. So in this case, with possible false positive test, we followed our clinical intuition and we treated the person, and we noticed resolution of the dysfunction. So that's here's or this case highlights one of the shortcomings of the test. Um, Here, where this is a person 10 months out with kidney transplant after failed kidney as part of simultaneous kidney and pancreas transplant. The test results came back positive. We biopsied that person, and the biopsy did not show rejection. However, that person was having background DSA or baseline DSA. They were preformed before the transplant. Whether this is can this be coming from the old organs, or why the test was relatively high, it's kind of hard to say, but the test was positive and the biopsy was negative. So this kind of gets into the performance of the test. However, there are cases where it's positive and correlates with the biopsy. This is our experience with pancreas transplant alone, without kidney. And here we find good negative correlation. So the test is negative and the dysfunction resolves, or the test is negative and we do the biopsy and it's negative, or this one case or two cases here where we performed the test is positive, and our clinical diagnosis was rejection. So what is the test performance in our experience with our small numbers? So when we looked at the entire cohort, the negative predictive value was 91%. So that means if the test is negative, you're 91.4% of the time, this is going to be true negative. The positive predictive value, if the test is positive, there's 60% chance there is rejection, and the 40% may not be. Specificity, when the test is negative in the settings of quiescence, it was 80%. The sensitivity, meaning that the test is positive in the setting of rejection, was 77%. Because we know that in the first 6 weeks we have lots of false positive tests, we ran our analysis on the negative predictive value and positive predictive value beyond the 6-week mark, and still the negative predictive value is about 91.4%. The positive predictive value improved a little bit, so beyond the 6 weeks, if the test is positive, there's 73% chance that we're going to pick up rejection. When we correlated this using biopsy data only, as with the cases that I showed you, some were biopsied and some were not biopsied for a reason or another. So when we wanted to compare the test performance when we had biopsy, the negative predictive value was 93.3%. So that means if the test is negative, there's 93.3% chance that we're going to have negative for rejection on the biopsy, and the positive predictive value is 71.4%. So the summary of our experience in primary SPK recipients, donor-derived cell-free DNA when collected after 6 weeks from transplant highly correlated with negative and positive biopsy results. In primary SPK recipients, donor-derived cell-free DNA was often less specific or false positive when collected under 6 weeks. Primary SPK and PTA recipients with dysfunction and negative tests appear to have stable course with subsequent resolution of dysfunction. And while these results are encouraging, further prospective studies with larger sample size are needed to confirm these results. In summary, in general, for cell-free DNA is a non-invasive way to assess for acute rejection. The negative predictive value is higher than the positive predictive value, so a negative test may be more valuable, because if you have a positive test, not only that there may be rejection, there may not be rejection, But when you have a positive test, you don't know what kind of rejection that is going on. Is it cellular rejection or antibody-mediated rejection? So you still need the tissue to decide what is going on, because the treatment will certainly differ whether you're dealing with cellular rejection or antibody-mediated rejection. The test performance may be enhanced if it's ordered for cause rather than monitoring, and the test is costly, so cost has to be taken into consideration. The turnaround time is about 2 to 3 days, and maybe longer during holidays. And the tissue biopsy and tissue diagnosis remains the gold standard if rejection is suspected. So that concludes our talk, and I'm open to any questions you may have.
Thanks, Dr. Riyad. We can take any questions, and before I forget, can you click on the 3 dots in the upper right corner of Joshua Courthouse? Now that I've made other people the host, I can't make myself the host again. So I'll figure this out probably by 2022.
So you make host, okay?
Yep.
Host. And who else? So Joshua is now the host.
Perfect, thank you.
All right.
Okay, thanks. Does anyone have any questions for Dr. Riyad? Thank you for a great talk on donor-derived cell-free DNA. I think every time I hear about this topic, I've heard about it multiple times, and every time I hear about it, I think I learn something more, and it was really interesting to hear about kind of the results that you showed. So thank you.
You're very welcome.
All right, you're getting a couple of rounds of applause. And if there aren't any questions, if anyone has any, feel free to email them to me and I can forward them along to Dr. Riyad.
All right.
Okay, thank you. Have a great night.
You too.
Thanks. Okay. I will go ahead and introduce Joshua. Joshua Courthouse is the Organ Procurement Manager at LifeSource, Organ, Eye, and Tissue Donation, the Upper Midwest Organ Procurement Organization. He leads and supports the teams of donation coordinators, advanced practice donation coordinators, and the training and education program administrators at LifeSource, and is responsible for operationalizing initiatives aimed at increasing the number of people saying yes to donation and maximizing the number of organs recovered to reduce the transplant waitlist and save lives through organ donation. A native Minnesotan, Joshua recalls from an early age feeling the pull to help improve the health of his family, friends, and community. In his work as a critical care registered nurse in the ICU, he found himself repeatedly working with team members from across the LifeSource organization, supporting donors, their families, and working to improve in-hospital processes aimed at increasing the opportunities for donation in the hospitals he worked with. His background as a critical care registered nurse prepared him for and introduced him to the work of LifeSource. And in 2005, Joshua left the ICU setting and began his career at LifeSource as a donation coordinator, and years later transitioned to his leadership role. With 16 years of experience in the organ, eye, and tissue donation field, Joshua continually works to advance the LifeSource vision of everyone shares the gift of life, helping to reduce time on the wait list. And Joshua will be talking to us tonight. His talk is titled Offering Hope and Healing During the COVID Pandemic. Thank you.
Thank you, Christine.
Thanks.
All right, good evening, everyone. Let's go ahead and get started. So the title of our talk this evening is Offering Hope and Healing During the COVID Pandemic. I'll give a little bit more here in just a minute. But first, for those of you who may be new to the world or maybe haven't worked with us here in the transplant community, who we are. As an organization, we are dedicated to saving lives and offering hope and healing through organ, eye, and tissue donation. As an organ procurement organization, we coordinate donor evaluation and donor management, as well as perform the organ allocation, getting those life-saving gifts to our transplant center partners. We facilitate organ and tissue donation between hospitals and transplant centers throughout our 3-state area. And as a big part of that, we support donor families through that immediate stage of grief and loss and try to help them see that this is something that can sustain them for years beyond the loss and know that lives can be saved through organ, eye, and tissue donation. And a big part of what we do is also educating our communities to help them, to inspire them to say yes to donation, to check the box in your driver's license and register as a donor and talk with your family about organ, eye, and tissue donation. And a big focus of our work is in our 3-state home area of Minnesota, North Dakota, South Dakota. Our office is based here in Minneapolis, but we do have team members all throughout our 3-state area. So in thinking a little bit more grounding and foundational of who we are as an organization, a little bit more about kind of who we are and why we do and what we do, I would share with you our mission, that our mission is to save lives and offer hope and healing through excellence in organ, eye, and tissue donation. That our vision is that in the future, everyone shares in the gift of life, and that our values really center around the 5 words of respect, accountability, advocacy, life, and innovation. Put simply, the purpose of LifeSource is to save and heal lives, and that's at the core of our work every day. Our mission, vision, and values help to create clarity, focus, and strong alignment across our entire workforce at LifeSource. And our work is highly mission-driven, and it's critical that our team members, our customers, and our partners share in that connection to the work that we do in helping to find purpose in their role in the mission of donation. So with that, in the spirit of advocacy, I'd once again just say thank you for allowing me to share this information about our journey in the past year and where we're going beyond this past year with you here this evening. So tonight we'll be planning on covering our 3 objectives, which are how COVID impacted donation potential, as well as our safety measures that were implemented as a result of the COVID pandemic. And we'll also talk a little bit about in the future, how COVID pandemic has transformed the work of organ donation and what we're doing to plan for greater success in the coming years. We'll also touch on some key principles, like how we acted from a safety first principle, placing our people, including our own team members, but also the donors, the donor families, and our customers and partners first, with an eye on stewardship, how we prepared to weather the unknowns that were coming across the landscape of 2020, seeking to maximize donation in a time of significant decline in donation and transplantation. And we'll also share how we've adapted our processes to continue serving donor families and our transplant center patients, both now and well into the future. And speaking of the future, we'll touch on how we're moving forward, the things that we've learned, the things that we're preparing for, and how we're going to act in even greater ways for the many years to come. And with that, let's go ahead and get started. So I could find no better image to really describe the feeling of 2020 right around the middle of March than this. The COVID storm was on the horizon, and it was clearly encroaching into the upper Midwest. As cases started in the west of the United States, but then also popped up in the east, we all knew it was only a matter of time before it met us right here in the upper Midwest. And really, in that middle part of March, none of us really could have predicted what would become. On the 11th, LifeSource, we established a COVID-19 Planning and Command Task Force, established and including many leaders from across the organization, as well as frontline team members, as we looked to plan and act accordingly, really preparing for something that none of us have ever lived through before. On the 13th of March is when our Minnesota governor declared a Minnesota peacetime emergency. And then quickly beyond that, on the 15th, our first confirmed case occurred, as well as the schools in Minnesota were closed. As you all recall, on March 17th, by then, all 50 states had at least one confirmed case of COVID-19, which then became the truest form. Minnesota on the 21st, our first confirmed COVID fatality. And heading into the end of the month, the stay-at-home order, which exempted our essential workers, And at the same point, that stay-at-home order, which really most of us were being told that it would only last about 2 weeks. And I think a lot of people had a lot of optimism at that point that it's going to be a short-term thing and we'll get better. Quite a different period of time to live through. So as we moved into that phase of March, we very quickly across the United States and the world saw an increase in COVID-19 cases. Specifically, looking at the United States at the national level, we went from well under 100 cases on the left side of the screen there on March 1st to on the right side of the screen, March 31st, having about 100,000 cases. On a more local level, when it comes to organ donors at the United States, we saw a precipitous decline in that second week of March. As cases began creeping up on the East and West coasts, transplantation and organ donors began to precipitously drop off. And within that, a little more close to home, the UNOS area kind of talks about this North Midwest, and the CDC talks about the North Midwest when they talked about COVID-19 cases. And so in matching the North Midwest that we are in, we saw one of the sharpest declines right in the third week of March. Specifically in the Life Source donation service area of Minnesota, North Dakota, and South Dakota, we started off the year really strong. In 2020, we have our ups and downs, much like any other ICU in the area. There are weeks when we are doing 7 organ donors or 9 organ donors and multiple transplants coming from each of those organ donors. And of course, there are weeks where we have a little bit of quiet, I said it, that occurs, and we do our best to save as many lives as we can from each and every donation opportunity. But to be clear, we were on track to have a record year at the beginning of 2020. Then March came along. At the middle of March, cases stopped. And then it became an all-in focus to try and make any donation opportunity happen. With the stay-at-home order, we saw less referrals. People weren't going out. People weren't having accidents. Elective procedures were being canceled. It definitely impacted the organ donation potential. And I know many of you felt that as well. Across the United States, and I will have a different version of this slide a little bit later that shows the impact of this in a much clearer way. This is likely not news to any of you. In March, living donation really flattened the curve. I think that it's safe to say that this is not the flattening the curve that any of us were hoping for. But in the end, living donor transplants kind of came to a halt. And ever so slightly towards the end of March and into April, we were on track to have a record year across the United States for organ donation and transplants. And then we came to a point of parity at the beginning of April as all things came to a stop. Locally, locally across our 3-state area, we have 9 transplant programs. And what we saw for individual transplant procedures was also that precipitous decline. So from the middle part of March, right prior to COVID pandemic coming to the Midwest, having 25 procedures performed and then quickly dropping off. Overall, it was a solid start to the first half of March, and of course, a very flat part of the second half of March. A little bit of statistics there on activity overall. I'm going to move us into people and talking about some of the things that we did in trying to keep care and safety of our team as one of our priorities. So LifeSource being perfectly positioned right between hospitals who make the referrals to LifeSource and then transplant centers who save lives through transplantation, LifeSource is really tasked with managing that loss of life all the way through to the gift of life. And being positioned in the middle, we are quite unique, that we are not intra-hospital, which also means that we don't have a lot of access to things like PPE. So we had to hit the ground running. First of all, from prioritization, that keeping the main things the main thing. Donation and transplantation was our main thing. Everything else that didn't need attention, put it on hold. This is our main focus. How can we make donation happen? How can we support hospitals to make donation happen? How can we support our transplant centers in making transplantation happen? We quickly switched gears and we found ourselves normally we're guests in the house at hospitals. But for a lot of our hospitals, space was critical. And you think about the impacts of social distancing, sometimes they didn't want us there. And with visiting restrictions, families also weren't there. Or maybe there was one person there, but they were only allowed to be there for a certain number of hours per day. And we had to re-gear and think about how can we do our work to the greatest extent remotely. So we capitalized on that by working with many of our hospitals to gain EMR access so we can enter orders, that we can see all the lab results, that we can communicate very quickly and securely with our hospital partner while also being remote. Our goal was to sustain the same level of service to the greatest extent possible to make sure that donation would have a great outcome. It also gave us a chance to dust off all those things that we always talked about, like, hey, that paper form, someday we should really make that electronic. And we got there very quickly between the end of March and probably beginning of May. So many of our documents were converted to electronic forms. DocuSign became a major thing for a lot of us. And we just kept ticking away at things that we could do to make our processes easier while working remotely. We collaborated with hospitals because in starting donation starts with a donor family. That oftentimes we must work with a family to gain their authorization or to help them support their loved one's donor designation. And in the beginning of the COVID pandemic, visiting restrictions were in place all across our 3-state area. And they're very unique to each hospital. So families were oftentimes at home, and we found ourselves communicating with families through methodology like FaceTime or having a conversation over the phone. Not our first best where we want to be when we're looking to support a family who's navigating grief and loss, and it just had to be. And for those families, my heart goes out to them. And I'm also reminded that for many of them, they wouldn't know that this was any different. And that's where we tried to live up to that standard, that they wouldn't know this was any different. We conveyed the same level of care and concern to each of them as we helped them to say yes to donation. We were also really challenged by getting PPE. LifeSource, prior to this, we didn't have stocks of N95 masks available. Deceased donation is the forte of our work. And within that, you normally don't have to worry about your patient's breathing or having some sort of a respiratory involved infection that could place your team members at risk. Thankfully, many of our transplant center partners and our hospitals came through for us, and they donated PPE to us so we could make sure that we had what we needed to keep our team members safe when they were working within the hospital environment or traversing through the ICU trying to get to that donor family or to that donor to make donation happen. Which then set us up for getting N95 fit testing for all of our team members. And we don't have an employee health or OC health department at LifeSource. We are a smaller organization of about 170 people. And so it was all about engagement. As we looked across our workforce, does anybody know anybody who is an occupational health nurse or who has, the skills and talents and ability to do this for us? And indeed, we had a family member team member whose mother was an occupational health nurse and could provide us with fit testing. And then we also had to work through travel restrictions. With the stay-at-home order, we had to make sure that we had the right materials that we could have in our car to prove that, yes, we were exempt from that stay-at-home order, but also navigating the myriad strangeness of how can we get into a taxi and travel across from the airport in Fargo to get to the hospital when you're still supposed to be 6 feet apart and nobody has masks yet. It was an endless, how are we going to do this? How are we going to keep our people safe? How will we get there to make donation happen? In the end, I capstone it with, we're grateful to our hospital and transplant center partners for making masks and other PPE available to help us get through that immediate stage. From a stewardship perspective, I know that I'm not alone in this. Stewardship of our resources, both financial, but our personnel and others was critical. When we entered COVID, we were in a solid financial position, and we knew that there would be a downturn in organ, eye, and tissue donation as COVID spread quickly across our area in March. So we needed to act quickly and broadly to support and sustain the financial health of our organization. In the mindset of keeping the main things the main thing, all travel related to conferences, continuing education, any of that was put on hold. We did immediate across the board budget cuts, trying to keep our main thing, our people. that we could keep our people at LifeSource to make sure that we could sustain our mission beyond the immediate COVID storm. And as many organizations did, we made lots of difficult decisions with the eye keeping on our people and making sure that we could be ready when donation returned soon. And then that moves us into fulfilling donation. And really, this became how do we continue donation in the midst of a pandemic? So a little over a year ago, hard to believe it's a year ago already, we started experiencing organ donor referrals who were testing positive for COVID. So when that referral comes in, do the evaluation, and the percentage of referrals that were positive for COVID peaked in the fourth quarter of 2020 and then dropped steadily throughout March 2021. And unfortunately, as the positivity rate for COVID has gone up again this spring, we experienced a 10% increase through the beginning of April, with 17% of our vented referrals being currently testing positive for COVID. As you all may know, anybody who is currently COVID positive would not have the potential to be an organ, eye, or tissue donor. So that led us back into our process changes. Well, since we already knew that we were limited in where we could be, how long we could be on site, we were limited on our PPE, even though we had some donor supply or some supplies that were donated to us, we still had limited supplies. We did not get an endless supply of N95 masks, just like hospitals and transplant centers were struggling to obtain those materials, as were we. So when we had 150 masks available, and then we had to fit them to our clinical team members who would need them, that's about stewardship as well. So in thinking about that, how do we minimize risk, reduce the time of exposure while still safely doing our work? So we changed some things in our process. From the referral stage, immediately it was about assessing for COVID-19. Have they had any symptoms? Where have they been? Have they been exposed? Assessing the ICU capacity. Many of our hospitals throughout the three-state area were bumping up to 100% capacity, opening up secondary ICUs, creating backup plans and plans Bs of how they would sustain the COVID spikes that we all knew would come. That we would conduct a lot of our follow-up remotely versus on-site like we standardly did in order to give space not only for our hospital partners, but also reduce the exposure of our team members. Working through the myriad challenges of supporting families who were often at home and couldn't be in the hospital, not because their loved one had COVID, but their loved one maybe was involved in a traumatic accident, but because there were COVID patients on the unit, they wouldn't be allowed into that unit. So really, families were very minimally on site. They too were getting their updates via phone or FaceTime. Our on-site responses were really focused on kind of the key times of the case. At the case start, where we'd try to work with family, obtain samples, huddle with the hospital partners to make sure that we had a solid plan for managing the donor, giving us a chance to obtain samples for HLA or tissue typing, our serology, infectious disease testing, but also COVID-19 testing, starting off with PCR swabs, giving us a chance to do our physical examination, looking for that head to toe, and really, we wound up being on site for about an average of 6 hours. Now, mind you, the normal time frame from a case is about 36 to 48 hours from the time that we first meet with family until the time we exited the operating room. The average organ donation case takes between 36 and 48 hours. So we were condensing everything we could do in the front end of our case into a 6-hour period of time, and then removing ourselves and managing that donor case remotely from our LifeSource office in Sioux Falls, Minneapolis, or Rochester, or from our own homes while we tried to take advantage of a strategic opportunity and be distanced in our own homes. Beyond that, for donor management, we were doing those things remotely, and we would quickly work through donor management, work with hospital partners to tweak the donor management based on each set of labs that came back, and we would allocate those organs remotely. And then return prior to the operating room to make sure that all the I's were dotted, all the T's are crossed, that things are good and ready for a smooth transition to the operating room for organ recovery. And within that, you may all recall that there was lots of guidances coming out from AST, ASTS around don't be flying recovery teams across the country to go get organs. Instead, how about everybody in Minnesota just recovers organs in Minnesota for transplant centers outside of Minnesota, rather than having a New York team come in to recover the heart for the recipient and then flying back. There was risks and concerns about exposure. And once again, LifeSource found ourselves in the middle of trying to be the middleman between donor hospitals who had concerns about all these people coming into their hospital when they were trying to minimize everyone else from even visiting their loved ones. Here we are trying to bring in a dozen people to make this work happen. So lots of collaboration with hospitals to try and navigate a path to make each and every donation case happen. Certainly, there was also additional PPE requirements. Hospitals were requiring some of our transplant partners to wear N95 masks. And we are finding that at different hospitals, there were different policies where one hospital would say, well, as long as nobody's COVID positive and doesn't have symptoms, they don't need to wear a mask. Where others would say, doesn't matter, you're wearing a mask when you're in the OR, an N95 mask. So then it would be, hey, transplant center who's coming to recover, make sure you bring your mask with you. And then there's the masks while traveling. In the LifeSource donation service area, we have 279 hospitals where we can do donation recoveries at. Most commonly, they're done at about 26 different hospitals each year. So within that, though, to get there, it's planes and automobiles, ambulances, town cars. And within that, there's also the concern there too. If you have 6 people in a car, how do you keep them safe? They're not able to social distance. It's masks while traveling. So while you're in that town car, everybody mask up for the safety of everyone involved. And throughout all of our organ donation process changes, you know, we all lived through every day. It seemed that the CDC would change guidance, or another body would put out a new guidance document. And a good example, somewhere in the middle of last year, that there were additional things that were being added into, even though our donor tested negative for COVID, we wanted to make sure that we had to ask, and there was guidance around, are there other patients in the ICU who are currently being treated? Because that could put our donor at risk. There are ICU staff that have been confirmed or suspected to have COVID-19 infections. Again, concerns for the recipients. And are there other patients mixed within that unit? So the levels of assessment continued to grow. And in trying to manage that, we all did the best we could in partnering with our hospitals to get the information we needed and trying to convey it as we could to the transplant center so they can make that informed decision. So in the end, where all of these process changes took us to, well, how are we doing with all that? So across the nation, the broad view look, again, we have that precipitous drop in the middle of March. And by April, we started getting things together. There was some guidance in place. We had communication from organizations like AST and ASTS, CDC, OPTN, everyone started putting forward a lot more information. We learned more. We were learning in real time, and donations started to come up. While the average donors from February 1st to March 8th were just 263, the week of April 12th, we saw that increase. Bottom line is the difference there is we were still down 30% from where we were just at the beginning of March. We collaborated with our hospital partners and worked to make every single donation opportunity a reality. And certainly we have to give credit to our hospital partners who committed to supporting donation, even in the midst of a pandemic where they were running out of space, that they ensured us that donation and transplantation could still occur, even in the most of challenging circumstances. From a more regional perspective, again, with the kind of salmon-colored North Midwest, this slide is very busy. But on the right-hand side, I would point out this salmon color for the North Midwestern United States. The declines ranged anywhere from 62% in the Northeast to 7% in the South Midwest and 12% in the Northwest. In the end, there were areas like Northwestern United States where when the first couple of COVID cases crept in, they almost dropped to 0. And the number of donors by week really never recovered much beyond that all the way through to early summer. There were other areas of the country that continued to do quite well up until that end of March period. For the LifeSource more centric area, our initial drop, and then we leveled off. And that's where we left spring. And the true local activity from LifeSource's perspective really resulted in that very flat donor activity throughout the rest of April. April was an extreme challenge. We managed to move forward actually 7 cases in total. One of those not being able to move forward as a donor, but yeah, it was a challenge. This is a closer look at that slide that I showed you earlier at the beginning of the presentation, indicating at a more granular level just how we were doing as a donation and transplantation community in the early part of 2020. So for year-to-date transplants, when it started off with a comparison in blue of 2019 and the green 2020, you can see where 2020 was moving right ahead. We were on pace as a nation to do better than we'd ever done before. And then we crossed under for a short period of time, and we were underperforming the year prior. The dramatic decline really did stand out in living donation, in that the amount of living donation really did result in a flat curve for the rest of May. And more specifically, looking at deceased donor transplants by a week on a more weekly granular level, between February 1st and March 7th, we saw an average decline of about 20% across the board. And within managing all of this and trying to make every donation case happen wherever we possibly could, I'll share with you an example of our daily monitoring of hospital capacity across our 3-state area. So each day, we would check in with each hospital through the magic of Epic or EMR access, or sometimes even just speaking with someone on the phone to get a sense of where are our hospitals at. So if a donor case comes up today at, we'll say, Sanford in Bismarck, would we be able to manage that donor case there? Would they have enough capacity for us to stay for the next 36 to 48 hours while we made donation a reality for this family, for that donor, but also saved lives through organ and tissue donation? In keeping track on the available ICU beds, we not only had to keep assessing the referrals and the cases, but also asking the question, can you support us being there for the next 2 to 3 days? It really came down to collaborating, planning, and assessing each and every day what we could do. Looking in and partnering with our hospitals to find out, do we have enough supplies, materials, and equipment there, or what would we need to bring along with us to sustain us through those next 2 to 3 days? Acknowledging the family support logistics in all of this, especially when the hospitals are at the red, our families are really kind of put to the side for a little bit because everything else was the more extreme priority. And of course, the logistics challenges in all of this, that our surgeons are in different areas, our LifeSource team members are in different areas, and traveling to all of these different hospitals through our 3-state areas presented challenges. But within all that, by mid-2020, mid-March, screening and evaluation was really kind of the key. Screening, where were they at? What was their symptoms? Do they have any symptoms? And then the donor risk assessment interviews really helped us to get some good insight into what risk factors may be present in any given donor opportunity. And in short, at the beginning of 2020, when the COVID pandemic hit, if there was any exposure or any symptoms, it resulted in a rule out. Very quickly, PCR testing became available. And remember each day on the news how you would hear about another hospital system is able to do testing. And each one of those days was a win for us because that gave us a chance to screen that referral just a little bit more before it would result in a rule out. By late March 2020, LifeSource had already partnered with local hospital laboratories to begin PCR testing nasopharyngeally on all of our organ donors. And by the 20th, we had partnered with VRL, which is our serology testing provider at the LifeSource facility, as well as ultimately kind of a handful of hospitals throughout our 3-state area to make sure that PCR testing was available for every donation case. And then fast forward to May 2020, we started getting more guidance, both for transplant centers and for OPOs, which really brought us to now that organs from deceased donors who are COVID negative or who had been COVID positive and are symptom-free for greater than 28 days prior to procurement, they're good to go. And with repeated negative testing, we're able to move forward with organ donation and transplantation. So if they're positive, or if they've had symptoms in the last 21 days and there's no time for resolution of symptoms, that would be a medical social rule out. However, if we're getting close to that 28-day period, we have time to do a couple of PCR tests. If it's going to be a lung donor, let's do a BAL. We had an opportunity to rule in those donors, even those who were past COVID positive. And as time has worn on, you can imagine a lot more of our referrals were COVID positive in the past. So these guidelines have been profoundly helpful in making sure that we're keeping safety in mind. And many of you probably know that today is the day that OPTN put a regulation into place that all lung donors will have BAL testing. LifeSource started doing this late in 2020. It became a national standard today. Thanks, OPTN. So beyond all of the struggles with COVID-19, the logistics, the challenges, supplies, materials, and equipment, there was that pause that gave us some space to say, what else can we do? How else can we try to maximize and save as many lives as we can from each and every donation opportunity? I'm going to share with you this slide. During that world's pause, we saw an opportunity for innovation. With greater capacity amongst our transplant centers, they're telling us that we have some space, we got some time, we have some people available, this is our chance. We resumed planning for our dry runs for DCD heart, so donation after circulatory death donation. And aside from the struggles of the early part of 2020, a highlight on the horizon was this: the facilitation of 2 local DCD heart donors who were able to donate their hearts for transplant. Those DCD heart transplants are being done through a national clinical trial utilizing normothermic perfusion through the Oregon Care System through Transmedics. And 24 transplant programs are participating in the study, resulting in nearly 100 successful transplants to date. Excuse me. The man you see on the right here, this young man is Wyatt. He was our very first donation after circulatory death heart donor. Just 2 months after getting his license in September of 2020, then 19-year-old Wyatt was lying in a hospital bed with non-survivable injuries. He had checked the donor box. Thanks to Wyatt and his family's generosity, the heart recipient is thriving. Evaluating DCD donors for the potential of heart donation has since been integrated as a standard part of our routine and a part of our practice. In fact, we've now had a total of 4 DCD hearts recovered and transplanted, 3 at outside transplant centers, and 1 here locally at Abbott Northwestern. So in the end, as we look kind of broadly at the year that was 2020, if we look at the blue lines, that's 2019 and green is 2020, a year-to-year comparison, COVID definitely impacted our work. It transformed it, and through it all, the challenges of March, April, May, and June, we accomplished nothing short of miracles. Our partnership between organ procurement organizations and transplant centers resulted in lots of lives being saved. I also sometimes like to take a look at the overall numbers and say, you know, in 2019, we had 206 organ donors. In 2020, we managed 185. It's essentially like we took a month off, although it didn't feel like we took a month off. Across the United States, the number of deceased donors and transplant activity in the end, very surprisingly and very proudly, we would say we actually turned out better than we thought we would. So 2020, the number of deceased donors actually increased by 6% overall, and the number of deceased donor transplants also increased by 2%, which is really amazing considering all of the challenges that we went through in the middle of the year with COVID. And looking at this longer term, so where does that put us on pace for how we've been doing? Well, in 2020, more than 33,000 lives were saved through organ transplantation. And much of the increase in deceased donation was made possible by donors representing those less traditional medical criteria. For example, for the second straight year, the most common age range of deceased donors was 50 to 64. And of the 3,726 donors in that category, those donors increased by 7.9%, almost 8% since the year prior in 2019. Donation also increased significantly among individuals who died of cardiorespiratory death as opposed to brain death. And those 3,223 donors who were DCD donors increased by 18% from 2019. Overall, from 2010 to 2020, a 58% increase, and just a 6% increase between 1 year ago. Well, now 2 years ago. Bringing that a little more granular and taking a look at the difference between brain dead and DCD donors. So for 2020, this is where we ended it up. For donation after circulatory death donors, there were 3,223, with 9,365 being brain dead donors. And in the end, for LifeSource, and for all of you in our transplant center service area, despite many hurdles, it did wind up being one of our second strongest years for organ donation. It is worth noting for our tissue and eye donation programs that they were actually paused for a portion of 2020 during the murder of George Floyd. We had to close our office and we had to relocate for a while and pause tissue and eye recoveries. So overall, with that, it's a year to be proud of, despite many hurdles. And with that, I'm going to pause for a quick second while I share a quick video that highlights the year that was 2020 for LifeSource and our area.
– 2019 was a record-breaking year, with more lives saved, families supported, and people checking the box, more than any other year in our over 30-year history. As 2020 began, LifeSource team members, ambassadors, and partners were excited to continue that momentum. Then, March 2020 arrived, and the world shut down. Confusion, unknowns, worry. Elective surgeries were canceled, driver's license offices closed, and access to hospitals was impacted. Everything changed, except our mission. More men, women, and children were being added to the transplant waiting list every day. They were counting on us for a second chance. Despite the adversity, we had to make the impossible possible. LifeSource team members and recovery surgeons were deemed essential personnel in hospitals. Hospital partners provided us with N95 masks and gloves. Every potential donor was tested for COVID-19. We supported grieving donor families on the phone and Zoom when meeting in person wasn't possible. Our staff and community made masks for funeral homes. Celebrations were held virtually. LifeSource ambassadors found new ways to advocate. May 25th, 2020. A tragedy in our backyard. The community responded with both peaceful protests and riots. Curfews and street closures followed. We took precautions to ensure our team and building were safe. Reaching our partner hospitals was difficult. May 30th, 2020. In the height of the civil unrest, our team received the call from a Minneapolis hospital. A young man named Tristan had died, and he had the rare opportunity to donate his organs. We had to get there, for Tristan, his family, and the transplant patients waiting for their perfect match. Thanks to a variety of heroes who stepped forward to help that day, Tristan saved 4 people's lives, including a young mother and Gary, a husband and father. Despite all the hurdles that 2020 threw at us, we found ways to continue saving and healing lives through donation, and it truly became a light in all that darkness. For hospital staff, for families, and for our LifeSource team, Innovation is often born out of necessity. The challenges of 2020 transformed us in new and remarkable ways. And for that, we are grateful. Thank you to the generosity and compassion of the donors and their families. Thank you to the dedication and innovation of hospital staff and transplant professionals. Because of your grit, your adaptability, and your commitment to our mission, you continued saving lives and honoring legacies. We are still standing, united in this mission of service.
So with that, I turn forward to the future. What's on the horizon for LifeSource? Certainly, we are making adjustments at each step to ensure that we're prepared to focus on growth once the effects of this more immediate crisis, if you will, are past, while keeping a keen eye on the opportunities for the future. We've made adjustments to our strategic plan, prioritizing those initiatives that are most critical to carry on today and help us to be prepared for subsequent years. I'm going to share with you a little bit about what we're working for our future at LifeSource and share a couple of our bold aims. The first is to save 1,000 lives through organ donation and transplantation by the year 2027. As we all know, the waiting list continues to grow every minute of every day. We know that we have made progress in our quest to save more lives in the past several years, and to that achievement we have celebrated, and yet we can and we must do more. While we have made significant gains, we cannot settle for being good enough when it comes to saving lives. The stakes are high, and we have to be bold in our commitments. To give you some context of just how bold this goal is, last year we wound up saving 603 lives through organ donation and transplant from our local donors. And in 2019, our biggest year for donation in history, we saved 635. So you can do the math. We are asserting that we will save 365 more lives in 2027 than we have in any year to date. That's an increase of 57%. This is possible. These are certainly big stretch goals for our future, and they're doable. And I'm confident that together that we will achieve these targets. It'll be through a combination of expanding both the number of organ donors and through the utilization of available organs that will help us to achieve that goal. We will be focusing on how we deliver our organ donation service. For example, in our 3-state area, we're focusing on the city of Sioux Falls, in that Sioux Falls has a great donor potential, but yet they've had very few organ donors. So we are looking at retooling our staff and our program in the city of Sioux Falls to try and have a greater response there, but also greater presence, in the hopes that we can advance our mission and have more donation in the city of Sioux Falls. Lots of great transplant centers there and hospitals. Certainly, we're also working to increase authorization, helping families to say yes in the midst of grief and chaos and loss, and working publicly to really encourage people to sign up and be a donor by saying yes on their driver's license. Working with transplant centers and physicians and intensivists across hospitals and transplant centers both, in helping us to support families and helping them to say yes. Working with transplant centers in really helping to fully evaluate each and every organ opportunity when it's offered, and smartly being innovative and taking intelligent risk and making sure that we have the right people and the right spots at the right time to help us achieve this mission by 2027. And within that, I would say that is our overall goal, is that we are saving more lives through organ donation by doing those two big things: increasing authorization, but also maximizing the organ utilization. And I would also like to share one of our other key initiatives that we've begun, which is inclusion, really supporting our work around reflecting the diversity of our community by increasing our presence and supporting our communities in greater ways by 2025. And also increasing equity and helping people to say yes to donation by 2030. And that we cannot do it alone, that it takes all of us to create a future in which no one dies on a transplant waiting list. 2020 gave us the opportunity to refocus on the importance of diversity, equity, and inclusion in our work, and in advocating for them in our greater community. LifeSource has been dedicated to collaborating with the diverse communities in our area and working to increase knowledge and support of donation for many years. With this bold aim, we're now elevating our commitment to our organization and our community. The slide that I'm sharing with you there shows, on average, when people are asked to authorize in a moment of loss, on average, families about 64% of the time will say, yes, we'll do that in that hospital setting, in that immediate stage of loss. However, it's quite different for American Indian, Asian, Black, or multi-ethnic background families. The authorization rate is much lower. And working with our community engagement in trying to connect with people, communities of color, and really understand what could help with that, knowing that there is a large percentage of folks from those communities who are on the transplant waiting list. So we've identified a couple of key areas here. First, we're committed to reflect the diversity of our community by 2025. Internally, looking to really seek, hire, promote, retain persons of color to help us really walk the walk and talk the talk when it comes to reflecting diversity in our community. We know that 17% of the people across our 3 states are people of color, and yet only 8% of our workforce at LifeSource is a person of color. We are committed to making sure that our team at all levels reflects diversity as evidenced in our community. Secondly, we'll work towards equity in participation in donation. Really that our communities of color say yes to donation at a lower rate than the majority population. We understand that this is an extension of the inequities that exist across healthcare in general, and we're going to do our part to continue expanding our important work in the community to increase collaboration and advocacy for donation. And in the end, I would just say and pause and say thank you, that I'd like to offer my appreciation for your partnership, because in the midst of this pandemic, together we can make miracles happen, and we did, and we will, and we'll make donation and transplantation happen for the years to come. I really want to say thank you for your collaboration, but also thank you for inviting me to share this information here with you today. And I'll pause for any questions.
Joshua, thank you so much. I will not turn my camera on because there were some tears that were happening over here. And I was thinking to myself that I feel like every time I see someone from LifeSource speak, I have tears. I'm a bit of a crier for those of you who don't know me. But just wanted to say thank you so much for sharing about kind of how LifeSource experienced 2020 and about the amazing work you guys continue to do and your goals for the future. Thanks so much for sharing.
Thank you, Christine.
Please feel free if anyone else has questions, unmute and or put them in the chat and I can read them out. All right. Can I ask you one favor?
Absolutely.
Can you maybe make me the host again, please?
Absolutely.
Thank you. I will learn Zoom probably by 2022 when we don't need it
Put it
anymore.
on your personal goals. Thank you, Christine. I will stop sharing
Right,
and I will
exactly.
make you host.
Yes.
Thank you, everyone. Have a safe Memorial Day.
Thank you so much. Just a quick kind of closing here. Thank you, everyone, for joining us tonight. Really appreciate it. Again, if your name did not show on the Zoom meeting, if you called in or you were on an iPad, please go ahead and reply to my reminder email just to let me know that you were there. And I'll go ahead and send out an email with both a link to the recording on the YouTube channel, as well as a link to a survey to obtain contact hours. And then again, look for emails coming about membership renewal and for our summer meeting, date will be July 8th, and for our fall conference coming up. So if you have any questions, please feel free to reach out. Otherwise, have a great night and thank you for joining.
Thanks, Christine.
Thank you.
Thank you.
Thank you.